So good afternoon, everyone. I'm going to talk about the role of immunotherapy in early triple-negative breast cancer. So we all know that breast cancer is a dreadful disease. Incidence is increasing as the years go by. About 178,000 new cases. The thing that bothers us is that there is almost a 50% mortality. And the whole goal for conferences like this and for getting clinicians and pharmaceutical companies to kind of get together is to bring mortalities down to improve patient care. Now we know in the Western literature, triple-negative breast cancer has been accounted for about 15 to 20% of all breast cancers. However, it seems like in India we are dealing with slightly increased incidence of triple-negative breast cancer. Why this is so, we don't know, but we are definitely seeing a little bit more of this disease. We all know that biologically it has a much higher risk of recurrence and metastasis. And we know that the time to recurrence for triple-negative breast cancer patients, if they do recur, is shorter compared to patients with hormone-positive disease. So the average time to recurrence is around 19 to 40 months, which is within the first 3 years. And if these patients have a distant recurrence, then the 3-year survival rate is pretty dismal, 23%. So we want to try and avoid recurrences in these patients as much as possible. Survival rates, like we just said, that if you have a distant recurrence, they are not so good. In terms of subtypes of triple-negative breast cancer, this is a molecular profile of the triple-negative disease. We know that not all triple-negative breast cancers have the same biology. And by trying to understand what the tumor microenvironment is, trying to understand how the tumor can be targeted is, when we're looking at immunotherapy, we're looking at the immunomodulatory form of triple-negative breast cancer, because it is associated with increased tumor infiltrating lymphocytes, high CTLA-4 expression, high PD-L1 expression, and all these things make it a good target for immunotherapy. Currently, for early triple-negative breast cancer, chemotherapy is the primary backbone for these patients. Combination chemotherapy is something that we have been using. And when we look at triple-negative breast cancer and treatment with chemotherapy, traditionally we see that for patients who have received neoadjuvant systemic therapy, there is a pathological complete response of around 35 to 45%. When we add immunotherapy, mainly pembrolizumab, which we're going to discuss about the Keynote 522 trial, but when we add immunotherapy to chemotherapy, this pathological complete response rate is increased by almost 20%. And we all know that for triple-negative breast cancer patients, achieving a pathological complete response is a good surrogate endpoint for overall survival and for event-free survival. So I'll come back to these slides. So why are we talking about immunotherapy in early triple-negative breast cancer? The number one reason is that in all breast cancer subtypes, triple-negative breast cancer is probably the only subtype which has shown a good enough benefit from adding immunotherapy. There are trials looking at immunotherapy in hormone-positive breast cancers, but the benefit is not that substantial when we look at the cost and we look at the side effect profile. So looking at the Keynote 522 trial, which is what got pembrolizumab approved in this setting, it is a randomized trial, 2:1 randomization for patients with triple-negative breast cancer, early stage. So which patients were included? Any patients with node-positive disease, or if the patient had disease which was less than 2 centimeters or node-positive, tumor size more than 2 centimeters or node-positive, they were included in the trial, regardless of the PD-L1 expression. Like all immunotherapy trials, if a patient had active autoimmune disease that required systemic treatment, within 2 years of treatment they were excluded because of a higher risk for immune-mediated toxicity. and if they had medical conditions that required immunosuppression, because that would effectively decrease the efficacy of immunotherapy. So patients received pembrolizumab versus placebo in combination with chemotherapy. The chemotherapy backbone included carboplatin and paclitaxel, either on a weekly basis or a 3-weekly basis, and doxorubicin or epirubicin plus cyclophosphamide, so the standard chemotherapy regimen, but it included carboplatin. The main efficacy outcome measures were pathological complete response rate and event-free survival rate. Overall survival was a secondary endpoint. If we look at the baseline characteristics, median age was 49, so relatively a younger group of patients, predominantly whites. Premenopausal 56% patients, so again younger patients. And if we look at the tumor size, majority of the patients had T2 disease, so between 2 to 5 centimeters. Node negative patients were 49, so almost half of the patients had no nodal involvement. 40% patients had N1 disease, and N3 disease was only 0.2%. So majority of the patients were stage 2. So this, as we had discussed earlier, PCR being a surrogate endpoint for EFS and for overall survival, especially in triple negative breast cancer patients. When we look at the immunotherapy plus chemotherapy arm, the pathological complete response is 64.8%, 65% compared to almost 50% with the chemotherapy alone arm. And this is what is driving the use of pembrolizumab. Irrespective of the nodal status, there is a higher PCR rate with immunotherapy. So even node negative patients at baseline, there was a higher response. And at the first event-free survival analysis, pembrolizumab at 18 months, we are seeing a difference, 91% versus 85%. If we look at patients who have achieved a PCR versus not achieved a PCR, the event-free survival in the patients who have achieved PCR is 94% versus 92%, so a small difference of around 2%. However, if patients who have not received a PCR, we are seeing a bigger difference in these curves. So if pembrolizumab is given adjuvant, irrespective of the PCR status, irrespective of the PD-L1 status for 9 cycles after surgery. And for patients who have not achieved a PCR, at least from this study, it seems like they have a higher benefit of getting adjuvant pembrolizumab. 56% versus 67.4%. Looking at the safety data, all diarrhea, all grades about 40%. In the immunotherapy arm, slightly higher than the chemotherapy arm. Skin toxicity, about 30% versus 24%. And there is probably a slightly increased risk of fever, decreased appetite. Majority of these side effects are grade 1 and grade 2. So pembrolizumab, if you look at all subgroups, there is a benefit of adding immunotherapy to the chemotherapy regimen, a statistically significant difference in terms of EFS. So to summarize, the estimated event-free survival at 24 months was about 88% in the Keytruda plus chemotherapy arm versus 81% in the placebo chemotherapy arm. At 36 months, we are seeing a maintained EFS 84% versus 76%. So this is to show that even after the treatment is complete, we are seeing a continued benefit of using this combination therapy. And if you're looking at the pathological complete response, 65% versus 50%. So this is what got the drug approved. I think just in the benefit of time, we can probably skip the case detail. things to monitor while on immunotherapy, and I think why immunotherapy has probably is not being used as much as the studies are suggesting, is because of the concerns of toxicity. So when we are using immunotherapy in the early breast cancer setting, we are looking at long-term side effects. These side effects mainly are hyperglycemia, so new onset diabetes, hypothyroidism, immune-mediated pneumonitis, colitis, panhypophysitis. These are all things that we worry about when we're giving immunotherapy in these relatively young patients. And as a multidisciplinary approach, these patients do see all the treating doctors. We all need to be very cognizant of very early symptoms of immunotherapy related side effects. So unexplained fatigue, unexplained cold sensitivity, if you're seeing blurry vision, if you're seeing any cardiac symptoms, these should not go unevaluated. Okay, thank you.